Hello everyone, this is Philip Smith, and this is my presentation on implementing a sleep-wake protocol at HICU. It's a QI project for the DNP program. If you guys don't know me, I'm a nurse at HICU, and most of you should. And some of you have already taken the pre-survey for this project, and I appreciate that. Got some good feedback, which you will see perhaps later in this presentation. So let's get started. So what is sleep? Well, Merriam-Webster defines sleep as a natural, easily reversible periodic state marked by the absence of wakefulness and by the loss of consciousness. This is accompanied by the occurrence of dreaming, changes in brain activity, and physiological functioning, and goes on to say that it's made up of cycles of non-REM sleep and REM sleep, and is usually considered essential to the restoration and recovery of vital bodily and mental functions. So quite a lengthy definition there, but you guys have probably heard the term REM sleep before, and this is when we have most of our dreams. We'll learn more about that later. Interestingly, we sleep about 1/3 of our lives, but yet we don't know exactly why we sleep. But we are aware of the benefits of it and what happens when we don't sleep. So here's a brief history of sleep medicine. It began in 1929 when Hans Berger discovered EEG waves in humans. Then in 1953, Kleitman and Azarinsky defined REM sleep. Finally, in 1970, Dr. William Dement opened the first sleep lab at Stanford University. So you can see it's a fairly young field of study, and it's still a developing field. So these graphics basically summarize a typical sleep cycle. We usually experience 4 to 6 cycles per night of sleep, and within each cycle we go through the 4 stages of sleep. The stages are N1, N2, N3, and REM sleep. So N1 and N2 are considered the lighter stages of sleep. N3 is the deepest stage of sleep, and as indicated by the red circle, this is when our immune system is strengthened and when growth and repair of our cells takes place. And this carries over into REM sleep as well. So if we break it down, we spend about 5% of our sleep in stage N1, around 50% in the N2 stage, and about 20% in the N3 stage. Finally, we spend 25% in the REM stage. So we should be spending about half of our sleep in deeper stages and the other half in the lighter stages. And this is just a different perspective of a typical sleep cycle laid out in a more linear fashion. So with this graphic, I wanted to point out that the longer we sleep, the more time we spend in a REM sleep. And our lightest sleep, as you might expect, should only occur at the beginning of the night. Now this table shows some physiologic changes that occur during sleep. I wanted to highlight the cardiovascular changes in particular that occur during non-REM and REM sleep. As we can see, the heart rate, blood pressure, cardiac output, and peripheral vascular resistance, these all decrease during sleep. And this may explain why we have to increase our vasopressor drips at night, or maybe we have to give them supplemental oxygen because our respiratory drive also decreases. Now this graphic is called a hypnogram, and it quantifies the amount of time we spend in each sleep stage. And I got this graphic from an article that studied the effect of sleep fragmentation on a typical resident on call. And here we have that the alarm clock icons represent each time the resident received a page, which resulted in an interruption in sleep. So with normal uninterrupted sleep, we typically would see a nice smooth up and down pattern versus the fragmented sleep where we see this sort of jagged up and down pattern looks a little more chaotic. And this particular resident was interrupted about 8 times. And so if this were a patient, you could replace all the alarm clock icons with nursing cares, lab draws, noise, and other activities that occur in the ICU. So ICU patients probably get a similar pattern of sleep as you see on the fragmented sleep pattern there. In fact, one study found that ICU patients can experience up to 60 interruptions per night, which is quite staggering, so it's no wonder our patients have such poor sleep. So what are some physiologic consequences of sleep deprivation? Well, as you see, it can lead to increased lengths of stay, increased mortality, and decreased patient satisfaction, as indicated by the orange boxes. Now we see in the blue boxes that things like acute illness, medications in the hospital environment, these can lead to mood instability, autonomic dysfunction, blood glucose dysregulation, and as I've circled in red, these are the ones we should be most concerned about, which are increased inflammatory immunologic responses, insulin resistance, and oxidative stress. And this really has a negative effect on our patient outcomes. So let's talk about sleep in the ICU. What does the evidence say? Well, we know that 60% of patients report sleep disturbances. We also see that poor sleep in the ICU can cause hormonal imbalances, alterations in metabolic function, and impaired ventilation. And perhaps the most notable thing is that sleep disturbances can contribute to delirium. As we know, this is a big problem in ICUs, and this can increase hospital stays and mortality. And this can have effects long after the patient discharges. There's a syndrome called post-ICU cognitive syndrome. Some of you have maybe heard of it, but it's a collection of physical, mental, and emotional symptoms that continue to persist after the patient leaves the ICU. So they could have problems sleeping at home or problems with depression. And so that's something we should consider when we're trying to prevent delirium. So these are both environmental and physiological factors that disrupt patient sleep. These include patient care activities, diagnostic procedures, lighting, the inflammatory response, stress, and pain. The ones outlined in red are the most common, and these tend to be the most modifiable. In other words, we as nurses, HCAs, and healthcare providers, we can do something about this without using a lot of resources. For example, we can cluster cares, reduce noise, we can ease the stress of a patient by talking to them and controlling their pain with medications or non-pharmacological approaches as well. Let's talk about noise, because this is something we have some control over and we can reduce for our patients. Now, even though it accounts for only 20% of awakenings, the more we can do for our patients, the better. So what's a safe noise level anyways? The World Health Organization recommends 35 decibels in the day and 30 at night. So compare that to the ambient noise in the ICU, which ranges from 50 decibels to 65 decibels and peaking up to 95 decibels. So that's quite loud, and for reference, a gas lawnmower is 90, if you can believe that. And I do believe it, because have you heard the Alaris pumps go off? And it's quite piercing to the ears, but there are some things we can do about it. So here are some guidelines set by the Society of Critical Care Medicine. These came out in 2018, and it's a list of recommendations for critically ill patients. And they cover topics like pain, sleep, and delirium. These are just a few I chose, but one of these is using noise and light reduction strategies, and the other is using a multi-component sleep protocol, both of which are part of my QI project. Let's talk about assist control ventilation. The assist control mode is a volume cycle mode of ventilation that works by setting a fixed tidal volume that the ventilator delivers at a set interval of time or when the patient initiates a breath. Now, we know this is a very common vent mode in the ICU because it's lung protective, but does it improve sleep efficiency? Well, there aren't a ton of studies out there that definitively say that it does, but there is some evidence that it can increase REM sleep when using assist control versus pressure control at night. However, this is a conditional recommendation, meaning that it won't benefit every patient. It's possible some patients would hyperventilate and blow down their CO2, but our providers are really good about using this mode appropriately. They may be on pressure support during the day, but then they'll put them on assist control at night, and this will allow them to rest better if they have a big day the next day. Maybe they're getting extubated, or just so they can be more awake for the day's activities. Now, here are some take-home points about sleep in the ICU. Sleep quantity and quality. These are difficult to measure. Polysomnography is the gold standard to measure sleep, and with all these electrodes and wires that it requires, it's simply not suitable for the ICU environment. There's a reason why we do sleep studies outpatient. Now, the next point, there is some evidence that sleep protocols in the ICU are effective, but the resources needed to maintain these protocols make them difficult to sustain. And the data we get from these studies tends to be observational with confounding variables. And because it's observational, we truly don't know if the patient actually got healthy, deep REM sleep, even if they report that they've slept well. So this is, once again, difficult to measure. Medications such as melatonin and Precedex are pretty much the only medications that have been studied to offer some benefits, and even those studies aren't extremely robust. So just to reiterate, sleep is challenging to measure in the ICU. We can use observational tools like the Richards-Campbell sleep scale, which allows patients to articulate their sleep, but once again, these are still just observational. It doesn't actually prove that they are getting good quality sleep. So here are some recent sleep promoting efforts or studies that have occurred at the U of U and HICU. The first one here by Zach Drury, he was a nurse on HICU. Some of you may actually know him, but he did his DNP project on improving sleep quality in the ICU through a noise reduction time. This time was midnight to 0400, and he found that a reduction in noise levels led to improved perceived sleep quality among patients. And the next study here by Anna Wen, she is the lead APC for CT surgery right now, I believe, and she's helping me with this project as well. Anyways, her project in 2018, she did a sleep-wake protocol to reduce delirium in the CV-ICU and SICU. So her focus was reducing delirium. She found that a sleep-wake protocol is feasible within the CV-ICU and SICU, and that it did actually decrease the incidence of delirium. And this last study here, safety of implementing a sleep protocol in hospitalized patients by Linda Patterson, our own Dr. Courtney Scaife, and Alexa Doig. This was published in the American Journal of Surgery, I believe, in 2019. It was a randomized prospective trial of intervention to promote overnight sleep. It was conducted on stable post-op oncology patients, and they found that the intervention to decrease sleep disturbances can be safely executed in post-op patients while maintaining adequate symptom management. So this topic of sleep promotion and sleep hygiene in the hospital and in the ICU is something that people are looking at, and we as medical providers, it's important to us, and we're looking at new ways to try to improve sleep, because if we can do that, then we can reduce delirium and a host of other health problems. So what's the point of this QI project? Well, here are the goals I'd like to accomplish. The first is to have access to more interventions. The current sleep hygiene order is fairly limited. I think it has 5 or 6 interventions, but this is kind of an expansion of that, and hopefully we can do more for our patients. Next, I'd like to see if it's feasible for future use, and if it's something that staff would be satisfied with, and if it's something that will actually work for HICU and maybe other ICUs in the future. And I'd also like to create a sleep promoting culture where we as providers are thinking about sleep more as we care for our patients, and not writing it off just because we're in ICU and that patients are too sick to sleep. And that's simply not the case. We can do more. And studies show that nurses lack sleep knowledge, and they see this as a barrier to managing our patients' sleep. So equipping you guys with a little knowledge will hopefully help facilitate some sleep strategies in a safe and effective way. And ICU nurses are essential to elicit these changes in sleep practice. And knowledge is power. The more we understand about sleep hygiene, the better we can serve our patients. Okay, so how does the protocol actually work? Well, it's super easy. There's 4 simple steps for RNs and HCAs. At the start of your shift, simply take one checklist for each of your patients. Day shifters will use the wake checklist, and night shifters will use the sleep checklist. Number 2, determine which sleep-wake interventions are appropriate for your patients. And then number 3, perform and check off as many of the interventions as you can during your shift. And also, I would encourage you to talk to your patients, ask them if the interventions are helping or if there's something you could do better. And number 4, after each shift, place the completed checklist in my mailbox or in the collection box in the break room. You may also just take a picture of it, send it to me if you find that easier. Either way, hoping to collect some good data to determine if this is a good protocol and something we could use in the future. So which patients are going to be eligible for this protocol? Well, initially I had a list of guidelines where if the patient didn't meet all of them, they weren't eligible for the protocol. And I noticed we were missing out on a ton of interventions. So rather than making a strict protocol that only certain patients can be on, I thought, gosh, why can't we just make an exhaustive list of interventions that most of our patients can qualify for, instead of having this strict yes or no, they're on the protocol or they're not. And so this is how the project kind of evolved. So these interventions, they're customizable to each patient and are determined by nursing staff with the help of the providers as well. Some of these patients may qualify for a few, while the others qualify for many of the interventions. So whatever their medical condition is, there's almost always something we can do to help our patients sleep better. So let's go over the actual checklist. These are what they're going to look like. As you can see, there's a day shift list and a night shift list. And for obvious reasons, the night shift list is a bit longer, as there are more strategies that will occur at night while the patient is sleeping. So first of all, I think a brief discussion with the patient about realistic sleep expectations. This can go a long way. I've had a lot of patients complain about not being able to sleep at night. They're surprised that they're woken up so much. Maybe they haven't been in the ICU before, but ask them how they sleep at home. Maybe they sleep better with a sleep machine or a podcast, as one of the nurses recommended in the survey. Maybe they will do better with a family member overnight. Next, turn those lights on. How many times have you guys walked into a patient's room around 11 a.m., it's noon, all the lights are still off, the patient's just snoozing away? Well, this can be an opportunity to educate them on why you're keeping them awake and how important it is to maintain a normal sleep cycle. Give them something to listen to, turn the music on, maybe some books or puzzles. Whatever we can do to keep the patient awake and interactive during the day can help them rest better at night. Consider reorienting the patient to the date and time. This is a simple intervention that can be done, especially if your patient has some dementia or they're experiencing some delirium. Just update the whiteboard as well, make sure the clock is visible. These are easy interventions we can do. So here's an easy one. If the patient has hearing aids or eyeglasses, we can simply place them on the patient while they're awake during the day. This can help them to be more interactive and in tune with activities around them. And if they don't have them with them, have a family member bring them in. Speaking of family, we can encourage family to visit, whether it's in person or via FaceTime, because this may also help alleviate stress. Ambulation is super important. There's tons of evidence out there that early mobility promotes healing and reduces delirium, so we need to ensure that PT and OT orders are in place. And for patients that are able, we need to be walking them or getting them out of bed up to the chair at least 2 to 3 times a day. Now, if you're day shift, you've got plenty of help from PT and OT, but at night, you can try to get that 3rd or 4th walk done, as this will be a big help to the patient, help them expend some energy, and perhaps help them sleep better at night. And this isn't just for nurses. HCAs can also advocate for this for their patients, as long as it's safe to do so and within order parameters. Discussion during rounds. As nurses, we can advocate for sleep promoting strategies, such as retiming medications, discontinuing unnecessary labs, or asking for PRN meds for sleep, such as melatonin. If the patient has routine labs, maybe request to have those done at 6 a.m. instead of 4 so they can sleep a little longer. If your patient has been stable from a cardiac standpoint, maybe consider removing tele. Remove the Foley if it's no longer indicated. Same goes for IJs, central lines. The less things we have attached to the patient, the more comfortable they can rest at night. Consider restarting a home medication they take for sleep, if it's safe to do so, or maybe half the dose they take would possibly be an option. Now, one thing you should note, and I think this goes without saying, but medications like propofol or benzodiazepines, these should not be used solely for the purpose of sleep. Even though there is evidence that these medications increase the amount of sleep, they do not actually increase quality of sleep, meaning they spend actually less time in REM sleep. Timing is important too. As one provider pointed out to me, we shouldn't be giving melatonin, say, after 2300. We don't want the effects lingering into the next day. Massage therapy and music therapy, these are simple ways we can help alleviate stress and help with pain, and this can lead to a more restful night. Now, these therapies aren't available all the time, but they are great resources we have at Huntsman, and we should be taking full advantage of them. Now, the last 2 items here apply more to our vented patients. We should ensure a target ROS is established. We don't want to have the patient thrashing around or pulling at lines, but we also don't want to keep them overly sedated. So I think it's worth knowing what the goal ROS score is and keeping within those parameters. Also, unless it's contraindicated, sedation vacations. Those should be done once per shift per order. Now, if this is missed or done improperly, then we miss out on an opportunity to reduce or potentially stop sedation for our patients. And this in turn delays getting them back to a normal sleep cycle. Let's ensure we have good IV access during our day shift. The last thing we want to do is disturb the patient in the middle of the night by poking around for an IV when it could have been done during the day shift. So I had an RN recommend on the pre-survey the importance of collaborating with the oncoming staff. So I think that this is worth mentioning. We should make a plan for our interventions. We need to know what was during the day, what's going to happen at night. Good communication leads to better care. And if you're not familiar with Vanilla Ice, you're missing out. He's legit. Look him up. I promise. Okay, I digress. Now let's move on to the nighttime interventions. It's not uncommon to find lights on at 2 a.m. when the patient should be asleep. We should aim to have these lights off by 2200 or 2300. For patients that prefer some lighting, we can utilize our night lighting or dimmers as appropriate. We should close the blinds and window shades after dark to give the patient more privacy. Now, if we're talking about the doors and curtains going into the room from the hallway, these should only be closed when it's safe to do so. Like if your patient has delirium or need one-to-one supervision, then it's okay to leave these open. So what about earplugs and eye masks? There's some debate as to whether these actually help patients sleep or not. There's a few studies that show some improvement in perceived sleep, but we must remember that sleep is very individual. Not every patient will agree to use them. For example, patients with anxiety, PTSD, patients with restraints or that are sedated, we should use caution when using eye masks or earplugs for them because we don't want to blindfold them, making them more afraid of their environment. They're already stressed out enough, but overall it's a cheap option. Some people already wear them at home, so why not give it a shot? Just be sure that they can remove them themselves if they decide they don't want them. So here's some simple things HCAs and RNs can do before bedtime. Just make sure the water mug is filled up. We can offer toileting. We can set the thermostat to a comfortable temperature. Maybe we can even change the tube feed bags early at 2200 instead of midnight. So just simple tasks that don't take much time. Let's talk a bit more about noise. As far as this goes, as nurses, we can anticipate fluid bag changes before the pump alarms and maybe have the next bag ready, change it a little early if need be. We should be checking our drains and ostomy bags so we can prevent interruption in sleep. We don't want the patient calling in the middle of the night to empty an ileostomy when it could have been done earlier. And let's silence or change the alarm parameters to allow for less frequent alarms going off. Nurses, we should be checking these at the beginning of our shifts anyways. Whatever changes are made, just be sure the patient is kept safe. For example, don't turn off art line alarms. I know this has been an issue in the past, but instead, if the art line is bad, simply take it out or ask the provider if you can remove it. Now, one thing that isn't listed here, but I felt I should mention, is tracking hourly urine output. I had a provider mention on the pre-survey that for patients that do not have acute urinary issues or an AKI, reduce the frequency of blood pressures. If the patient is hemodynamically stable and or they have a good functioning art line, there's really no good reason why we should be checking pressures on the arm every 15, 30 minutes or every hour even. So consider just going off the art line if it's working well. Reduce taking temporal temperatures when possible. If a patient already has an ET tube, then maybe consider dropping an esophageal probe to do your temperatures. Or if the Foley catheter is equipped, we could transduce temps from that as well. So we talked a little bit about noise earlier, but this is a big one, and I believe it gets overlooked quite often. In particular, noise at the nurse's station. I've had patients comment on how loud it is out there, and we're all guilty of being too loud at some point at the nurse's station or in the hallway. But some of us are louder than others. I won't name names. It's definitely not me. Just kidding. It's probably me, at least sometimes. Nonetheless, as you can imagine, that's probably not pleasant for a patient going through perhaps the most stressful time in their lives, that they have to listen to loud chatter or cutting up out the nurse's station. And I'm not saying we can't have fun at work. Of course we should have some fun, but we should also be mindful of the noise levels that we get up to. And I think most of us would be agreeable if we respectfully asked each other to keep the noise down. Also, clearing the halls of people congregating or talking on their phones, this could also help mitigate noise. Finally, to finish up, I'd like to talk about clustering cares. We've all heard of this concept, but I think we get sidetracked into our separate roles and we end up disturbing the patient more than it is necessary. So nurses talk to your HCAs, HCAs talk to your nurses, and let's cluster our care so we're not waking the patient. Let's talk about the quiet time intervention. So for the purposes of this project, quiet time hours will be 2200 to 0600. You'll place a sign on the door at night. Ideal patients will be floorboarders, long-term admits, and patients on comfort care. But we should realize most patients will not be candidates for the quiet time, but definitely keep it on your radar for select patients. Now, quiet time can be tailored or modified for certain patients. For example, patients requiring Q4 assessments, vitals, or other interventions can still be placed on the quiet time, but the important thing is patient safety. So if you're unsure or the patient's a little unstable, let's get approval from the provider first. And to help, I put some exclusion criteria. Q1 flap checks, vasopressors, vented patients, delirium, etc. These patients should not be placed on quiet time. Okay guys, we're almost done, I promise. Here are the steps of the project just to recap. Number 1, to assess the staff's knowledge, attitudes, and interests, and currently use sleep-wake interventions. This step has already been completed through the survey I sent out last month. Now number 2 is to develop the protocol based on the survey results and the feedback I received from you guys, which I have already done. I got some great suggestions and incorporated it into the protocol. Number 3 is to implement the protocol, which will occur later this month and run through the end of February. And lastly, number 4, I will collect the data from the checklists and evaluate the number of new sleep-wake strategies or interventions you guys used, and I will determine if the protocol is feasible and if the staff was overall satisfied with it. So here are some frequently asked questions regarding the protocol. I'm not going to go through these right now, but if you guys want to review them, you can. Otherwise, that's the end of this presentation. Thank you for sticking with me, and I really appreciate you supporting this project. I look forward to the results we get. Thanks again. Have a good one.